Good morning, everybody, and the Subcommittee on Oversight and Investigation is convened. I'll start with my opening statement. We have convened this hearing of the Subcommittee to examine how the Department of Health and Human Services is implementing President Obama's executive order, which was announced on January 18th, entitled, quote, "Improving Regulation and Regulatory Review," end quote. Regulatory reform has been a priority of this subcommittee in the 112th Congress and will remain so as long as Americans suffer from prolonged high unemployment and sluggish economic growth. A 2010 study commissioned by President Obama's Small Business Administration placed the total annual compliance cost of federal regulations at $1.75 trillion, a number that trumps the record federal budget deficit. Cass Sunstein, the head of the Office of Information and Regulatory Affairs and primary overseer of the administration's reform efforts, disagreed with this study in his testimony before the subcommittee on June 3rd. This seemed to be a theme of the administration. If a study or report comes out that they disagree with, it is denounced as inaccurate or labeled an outlier, even if the administration actually commissioned the study themselves. Case in point is the White House response to a recently released study by the McKinsey Group, indicating a radical restructuring of employer-sponsored health benefits following the passage of the President's health care plan. Overall, 30% of the employers surveyed said that they will definitely or probably stop offering health care coverage in the years after 2014 due to the overwhelming burden and expense of Obamacare. And an incredible 50% of employers with a high awareness of the laws say they will stop offering coverage. White House Chief of Staff Nancy Ann DeParle shrugged off the report, saying it misses some key points and doesn't provide the complete picture. This study, however, is not an outlier. Two other reports have been released by reputable independent experts within the last month. Each one concludes that the Obamacare has made a coverage more expensive and that many individuals who like their current plan will simply be dropped from it. In fact, according to the administration's own estimate, cited in the interim final rule implementing the grandfathered health plans, its regulations will force half of all employers and as many as 80% of small businesses to give up their coverage in the next 2 years, as this graph clearly shows. President Obama's executive order requires agencies, when promulgating rules, to consider cost and benefits to ensure that the benefits justify the cost and to select the least burdensome alternatives. It requires increased public participation. It directs agencies to take steps to harmonize, simplify, and coordinate rules. And finally, it directs agencies to consider flexible approaches that reduce burdens and maintains freedom of choice for the public. I do not see how the regulations that will force as many as 80% of small businesses to drop their employees' health coverage can possibly pass any of these tests and criteria that the President outlined. Quite frankly, it seems like Obamacare itself has received a waiver from this executive order itself. In addition to prospective requirement agencies are supposed to adhere to while promulgating regulations, the executive order directs agencies to conduct ongoing retrospective analyses to identify rules that should be streamlined, reduced, improved, or eliminated. HHS arguably touches more aspects of Americans' daily lives than any other agency. FDA in itself regulates more than 25% of the U.S. economy. We need to ensure that the regulations it has on the books, as well as the ones it currently drafting, promote public health as well as private sector innovation and job creation. After all, the health and well-being of our citizens is inherently tied to the health and well-being of our economy. The number and size of the regulations that have been expedited through the review process at HHS and ORIA is matched only by the number and size of the rules still in the queue. Among these is the establishment of essential benefits package, which will increase premiums and further put people's coverage at risk. Hopefully, our witness today will share with us what HHS has learned from the process used to promulgate such rules and regulation as a grandfathered health plans rule. HHS will hopefully do better while reviewing the essential benefits package and other large rules coming down the pike. An unprecedented amount of authority has been delegated to HHS and other agencies in the administration. The principles President Obama affirms in his executive order are important. We agree. I am just concerned they are being ignored when it comes to the actual implementation of large-scale government programs such as the President's health care plan. I'd like to welcome our witness, Sherry Glide, who is the Assistant Secretary for Planning and Evaluation at the Health and Human Services Department. And with that, I recognize the Ranking Member of Energy and Commerce, the distinguished Henry Waxman from California.
Thank you, Mr. Chairman. The subject of regulatory reform deserves review, and Congress has a legitimate interest in making sure that the administration is living up to its promises with regard to making the regulatory process simple and more transparent. But as we investigate regulatory reform, we need to make sure we consider both the costs and the benefits of regulations. This is the third hearing in this committee on regulatory reform this year. In these hearings, the administration's opponents have relentlessly focused on the negative, with no regard for why we need regulations or for the good that they do. Regulations aren't pulled out of thin air for no reason. They exist to implement laws Congress enacted to help protect taxpayers' funds, improve public health and safety, keep our air and water clean, and keep consumers safe. Today's hearing is a good illustration. Some of the administration's recent health regulations will do enormous good for American families. New food safety regulations promulgated by FDA will reduce salmonella contamination and prevent as many as 79,000 illnesses each year. New tobacco control regulations promulgated by FDA will protect children and adolescents from the dangers of addiction to cigarettes and smokeless tobacco. New regulations issued by CMS under the Affordable Care Act will end the insurance industry's worst abuses. They will prevent health insurers from rescinding policies when beneficiaries get sick, end discrimination against children with pre-existing conditions, prohibit the imposition of lifetime caps on coverage, and require all health plans to put more of consumers' premium dollars into actual care and less into insurance company profits. Another set of CMS regulations, also authorized by the Affordable Care Act, will cut Medicare and Medicaid fraud and save taxpayers millions of dollars. No one wants unnecessary or duplicative regulations, but at the same time, no one should want to eliminate regulations that save taxpayers money and protect the health and welfare of America's families. That is why we must look at both the costs and the benefits of regulations. When we focus solely on costs, as often seems to happen in this committee, we lose sight of the critical benefits these regulations provide. Before I yield back my time, I want to note that Ranking Member Diana DeGette regrets being unable to attend this hearing. Today is a return day. We don't have votes until 6:30, and unfortunately, the ranking member of the subcommittee was not consulted about the hearing that was going to be called today before 6:30. In the last Congress, we engaged in a lot of these consultations. I think they're useful for everybody involved, and I would urge the majority to be sure to consult with the minority so that the minority ranking members of the subcommittee can change their schedules or can be accommodated in some possible way. I have completed my opening statement. I want to welcome Ms. Gleed to be here. We're looking forward to your testimony. I think what HHS is doing by way of regulations is very important, very worthwhile, And while any regulation may have some downsides, we have to realize that many of them have very, very important upside for the American people. Thank you, Mr. Chairman.
I thank the gentleman from California. I would point out that we gave 1 week's notice according to the rules for this hearing. But I also want to again reiterate we welcome Sherry Gleed. She again is the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. And Madam, as you know, the testimony that you're about to give is subject to Title 18, Section 1001 of the United States Code. When holding an investigative hearing, this committee has the practice of taking testimony under oath. Do you have any objection to testifying under oath? No? The Chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today? In that case, if you please rise and raise your right hand, I'll swear you in. Do you swear to tell the whole truth and nothing but the truth, so help you God? Thank you. You may now give your 5-minute opening statement. Thank you.
Mr. Chairman, Congressman Waxman, other members of the subcommittee, my name is Sherry Gleed, and I'm the Assistant Secretary for Planning and Evaluation in the U.S. Department of Health and Human Services. I'm grateful to have the opportunity to appear before you today to discuss issues relating to regulation and to Executive Order 13563, Improving Regulation and Regulatory Review. I'll focus in particular on the retrospective review of existing rules. The President's order laid the foundations for a regulatory system that is designed to protect public health and welfare while also promoting economic growth, innovation, competitiveness, and job creation. On May 18th, and in compliance with the executive order, HHS released our preliminary plan. HHS's systematic review of regulations will focus on eliminating rules that are no longer necessary and strengthening or modernizing rules where appropriate. For example, the Centers for Medicare and Medicaid Services is working to address conflicting requirements between Medicaid and Medicare that potentially create barriers to high-quality, seamless, and cost-effective care for dual-eligible beneficiaries. The Administration for Children and Families is also encouraging states' child support programs to use cost-effective technologies like electronic signature and document storage. And the Food and Drug Administration is going paperless with its adverse events reporting requirements for medical devices. HHS's retrospective review plan has 4 goals: to increase transparency, to increase opportunities for public participation, to set retrospective review priorities, and to strengthen analysis of regulatory options. This administration believes that retrospective regulatory review must be accompanied by efforts to make more information available to all interested parties, and that regulations and the regulatory process should be as clear as possible. HHS will increase transparency in its regulatory process by making available, to the extent feasible and permitted by law, information that is useful for businesses, states, local and tribal governments, and the public. It is essential that people be able to understand the basis of a proposed regulatory activity, including the science or evidence base for a regulation. Public participation is a very important part of our retrospective review plan. We are currently soliciting public comment on the HHS preliminary plan on the www.hhs.gov/open website through June 30th. Suggestions are welcome, and HHS will carefully review all comments before finalizing our plans. HHS also intends to increase the breadth and quality of public participation in its rulemaking and retrospective review activities. All HHS agencies already reach out to obtain public input and advice on regulations subject to review and modification. For example, twice a year, FDA sends letters to state and local elected officials and to small businesses highlighting upcoming regulations and seeking suggestions on FDA's regulatory activities. FDA also recently established a new web page specifically devoted to its regulatory review activities. CMS conducts monthly open-door forums and provider outreach activities. Feedback from these activities allows CMS to identify and change obsolete regulatory requirements and to reduce regulatory burden. Moving forward, HHS is establishing a public participation task force within the department to explore ways to increase interactivity in the public comment process, including the use of podcasts, webinars, video teleconference sessions, wikis, YouTube, and other social media. HHS has also actively encouraged public participation as we implement the Affordable Care Act. For example, we solicited public comment even before putting out rules around medical loss ratios, grandfathered health plans, and rate review. Similarly, CMS held public forums on wellness and exchanges to provide opportunities for public input by affected stakeholders. The last cornerstone of our plan is to strengthen the use of regulatory analysis, such as cost-benefit analysis. The Secretary has asked me to establish an agency-wide analytics team to share information, make the quality of analysis more consistent across the department, and ensure the integration of such analysis into regulatory decision-making to improve the quality of the regulations we promulgate. We've also redoubled our long-standing commitment to making regulatory review an integral part of our operations and culture. As our work continues in the months and years to come, we will rely on the 4 key principles I've just highlighted: increasing transparency, improving public participation, being clear about our priorities, and ensuring that analysis guides our efforts. Our department's mission is to protect the health and safety of all Americans. The plan we will be discussing today does that while promoting economic growth, job creation, and innovation. I look forward to working with you in this endeavor, and I'm happy to answer any questions.
Dr. Gleed, thank you very much. I'll start the questions here. What we have in the Oversight and Investigation Subcommittee is a little different. We try to get succinct answers because we're more of an investigative body rather than a legislative body. So if you possibly can, just keep your comments short. Just by backgrounds, I understand you're an economics professor at Columbia, is that correct?
Yes, sir.
Did your background include any health related things at being an academic professor at Columbia?
Yes, sir.
Is this your first job working in administration?
No, sir.
No. What other administrations did you work?
I worked for the first Bush administration back in 1992 and for the Clinton administration in 1993 at the Council of Economic Advisors.
And was that dealing with health?
Yes,
too?
sir.
Oh, say. So this, when you walked in this job, you didn't feel like you were walking into a brand new storybook?
No, sir.
Okay. How does Health and Human Service identify which rules that are already on the books will be reviewed?
We've laid out, after a process of public comment, a set of principles that are going to guide which rules we want to look at. And we've also opened our plan up to the public for further comment, so they can also suggest rules they'd like us to look at. But the main principles that guide our decisions are situations where circumstances have changed since a rule was originally promulgated, where new technologies or innovations have come along that should lead us to change how we do something, where there's been a failure to realize public health benefits that were anticipated on passing the rule. So, for example, HRSA, the Human Resources and Services Administration, has rules that were promulgated back in the 1970s defining health professional shortage areas. That's a real priority for us to go after because it's been a long time since we've looked at those rules.
You indicated there might be public comment, too, or
yes, sir.
Public can submit to you rules that they think are outdated, too.
That's correct. The website is open for comment through June 30th.
Once a rule is identified for review, possibly reform or elimination if it goes back to 1970, what's the next step and how long does the process take?
I think that we will see that as we go through each rule. Each rule will go through a careful analysis, including redoing the regulatory impact, trying to assess what the impact of that rule is and what potential for modification or rescission of that rule might be appropriate.
So is it possible that you could interpret through your office a way to enforce a rule in a totally different manner?
We have to abide by the statutory authority under which the rule was promulgated, but we could look at that rule and come up with better ways of doing it.
But you're saying you could also decide not to enforce it?
Only if that would be consistent with the statutory authority under which the rule was promulgated.
Well, if it's on the books and it's statutory authority, how could you suddenly decide not to enforce it?
We would have to enforce it. We might come up with a different way to enforce it, a different way to implement the authority.
You'd come up with a new interpretation?
Correct.
Would this go to public comment?
All of our rules do go to public comment, yes.
And how long is that public comment?
There's a standard process where we might put out a notice of proposed rulemaking and seek public comment on that. I don't remember exactly how long it is. A couple of months, I think.
Have you identified any rules already? I mean, how many rules have you identified to date?
So the first part of this process was for the various agencies within HHS to identify rules that they thought were important. We've identified many rules, I'd say dozens of rules already that we're looking at. In a separate and parallel effort, CMS has looked at its own ways of doing business and has identified 80 practices, including rules that it's going after. So there's a large number that we're investigating.
So you're saying at this stage you've identified in your office 12 rules?
Oh no, more than dozens.
More than
more than a dozen.
So would you say 48 or 24?
I don't have the exact number before me, and we are waiting for public comment to get more rules in, so we anticipate that we'll get quite a few.
Is there anybody on your staff who could tell you how many rules you've identified so far? Just approximately.
Probably.
Are we talking about 10?
20, 25 so far.
25? Okay.
I don't want to be,
No, I'm not going to hold you to it. It's just a round figure.
And we are waiting for public comment to get many more.
Of any of those 25, have you decided not to enforce any of those 25?
We haven't, no, we have not decided not to enforce any of them. We are looking at ways to revise them. For example, to recalculate how we would determine a health professional shortage area, or to change the way we use symbols and device labeling in FDA.
And so the criteria, I'd like to understand, on how you decided to select those roughly 20 rules, how did you single those out? Was it based upon age on the books, or based upon implementation not working, or is it based upon not clear? What
we laid out a series of criteria, including that there were new technologies, that there had been changes in circumstances, right? The ones that I had mentioned earlier. So we looked at them. We asked all of the agencies to look at the rules on their own books to see ones that made the most sense to modify, where they had opportunities to modify those rules and seemed that it looked like it was important. And now we've opened it up for public comment so that other people can also tell us where they think we should be looking.
It seems to me that, you know, the executive branch issued this executive order to look at these rules, but as I recollect, it's already on the books that HHS should be doing this on a regular fashion. Isn't that true?
That's true. There are several authorities under which we already look at rules, so the Regulatory Flexibility Act.
So would it be fair to say that the executive order really wasn't necessary because the legislation is already on the books to do exactly what you're doing, and it wasn't necessary for the executive order to be issued?
We have routinely within the department looked over our rules, and even before the executive order came forward, we had rules that we were working on. But the executive order does tell us to prioritize this activity, and that's what we've done.
In your plan, it says, quote, "The priority will be to identify regulations that agencies can easily modify, streamline, or rescind to address regulatory burdens or inefficiency." Do you feel this is strong enough?
I think those make sense as a criteria for us to look at. Yes.
I mean, you're saying one of your criteria is to take and prioritize regulations that are easiest to fix. Would also you determine what's the most impact?
Of course, you want to look at both.
I would think that that would be the criteria rather than easiest to fix, because you might be putting a parenthesis somewhere, and that's easiest to fix, but it really is a meaningless regulation, whereas you might have a whole set within that 20 that has huge impact, that would impact constituents.
As you know, Chairman Stearns, we want to weigh the costs and benefits of everything we do, including which regulations to pick.
Do you actually weigh the cost benefits? Do you do an economic analysis?
We do it for any regulation we put forward. We do an economic.
Even if it's easiest to fix? Well,
if it's easiest to fix, the costs of repairing it are very small. And that has to be taken into account. So we take into account both what can be done easily and what is most important to do, and both of those things need to be weighed.
Now, I'm sure this is pretty easy to understand for you. Aren't the most burdensome regulations the ones that are most complex? Is that a fair statement?
Not necessarily, Chairman. Sometimes there could be very burdensome regulations that are very simple.
Let me give you an example. Under the President's health care plan, this is a regulation, those covering medical loss ratios. You know, I've talked to insurance companies about this. Accountable care organizations and grandfathered health plans. These are pretty complex rules, wouldn't you agree?
Some of them are complex, yes.
Okay. Yet your plan says that that complexity on important rules would make it not a priority for your review. That's what we understand, that because of the complexity of it, you have not done a review, yet everywhere I go, people are talking about medical loss ratio, how complicated it is, and the impact it's going to have. It seems like that one would be one you would look at together with, as I mentioned, the grandfathered health plans, what that means, and accountable care organizations.
So, Chairman, you've spoken about 3 of our very important regulations under the Affordable Care Act, which promulgate regulations to really put forward a change in the U.S. healthcare system that I think is very important. Those regulations have only very recently been passed, so we're not going to look at them not because of their lack of complexity, but because there has been no change in circumstances, there have been no new technologies or innovations, there's really not much that has changed since we promulgated those rules that would lead it to make sense to look at them again within this short period of time.
Well, you both agree that you would look at burdensome regulations if they had a huge economic impact. I think you said you would.
We have just completed doing the economic impact analysis of those regulations. So we've already weighed their benefits and costs and shown that their benefits considerably exceed their costs.
Well, if I identified, let's take medical loss ratio as having a huge economic impact. Is it safe to say that you're going to look at that regulation in detail and allow the public to comment on it in the very near future?
Chairman, that regulation was actually developed after an extensive period of public comment, and we've assessed the costs and benefits. We estimate that the costs of that regulation for insurers are on the order of $100,000 per issuer to set up the plan, and $25,000 per issuer to continue maintaining the plan over time, and that it's going to generate $3 billion in benefits to American consumers over the period from 2011 to 2013. That's a great benefit-cost ratio.
Now, those analyses that you did are within your department made those projections, right?
That is correct.
That was not done by an outside accounting firm or an outside economic group. It was done by your people, right?
As with all regulatory impact analyses, those are conducted within the agency and reviewed by OIRA.
Have you actually sat down with the people that have been impacted, insurance companies? Do they agree? Because I have not heard any of them think that it's just going to cost $100,000 plus the very small figures that you. None of them have told me that, so I don't know where you get your figures.
Chairman Stearns, the rules for the medical loss ratio were actually developed by the National Association of Insurance Commissioners, which is an organization of all the state insurance commissioners from around the country. They're the ones who developed these rules, and we worked on the regulatory impact analysis in conjunction with those rules that they had developed.
Well, as you know, between the cup and the lip, if you develop a regulation based upon someone else, there could be some nuances of parsed language because the insurance companies are not coming back, at least to this member, and feeling the costs are so diminutive, as you pointed out. Let me go to another series of questions here. I think I have the opportunity to speak a little longer. I assume that there's no one on the Democrat side. I'm sure they want me to use my time as wisely as I could, so that I'll continue. Dr. Gleed, if you don't mind, I'll be glad to, if another member shows up, I'd be glad to. I'm told Mr. Waxman might come back. I hope he will. He has very good questions to offer you too. Dr. Gleed, you've released your preliminary plan for a retrospective review of existing rules. Is that correct?
Yes, sir.
This is a retrospective plan, though. Is that correct?
Yeah. This particular part of the plan is retrospective, yes.
Because it only looks backwards.
Many of the principles in the plan are also encapsulated in existing HHS practices. So the President had actually specifically called for retrospective review, but we actually have implemented those principles, both going prospectively, looking at the regulations we're about to promulgate, and concurrently the regulations that we're working on right now, as well as retrospectively, sir.
That's a pretty good answer. You have it both ways there. Of the 20 regulations, how many of those are retrospective and how many?
But those are retrospective. That's part of our retrospective review plan. But we are engaging.
Prospective?
So
rules?
prospectively, we're working on many regulations right now, and we've already implemented those efforts by, for example, increasing the transparency with which we put forward those regulations, by putting them up on our websites in a much more easy to access way, and by getting public comment even before we start the rulemaking process.
It's interesting, with the passage of the President's health care plan, there's so much regulation that involves moving prospectively forward. And so, yet you're talking at this point of retrospective. So I guess the question is, how would your office address prospectively all of the regulations from the President's health care? Because as this is presented and enforced every year, there's going to be much complexity and much angst. As you saw the graph I showed, small, medium, and large businesses, particularly small businesses, have decided almost 80% in the next 2 years they're going to give up their health care plan and they're going to go to the government option. So you see the angst is out there. So I guess the question is, how does your plan address these prospective regulations that are all part of the President's new health care plan?
So the Affordable Care Act offers great new opportunities for small businesses. As you know, they're already eligible for tax credits, and they will be able to buy insurance on much better terms. We're going to really level the playing field once those exchanges get going. As we develop those plans to get the exchanges going, to move into 2014, we are soliciting a lot of public comment, both in advance of rulemaking and as part of the rulemaking process, including a lot of public comment from small businesses, from providers, from insurers, from all affected groups.
Dr. Gleed, I think what you can hear from me is, based upon the graph I showed you and the angst that's out there, that retrospective is fine, but there's a huge, burdensome number of regulations that are being implemented as we move forward. And I think on this side of the aisle, we'd certainly like to feel that you're using your general principles that you mentioned in your opening statement are being applied to the rules for the President's health care, so that in addition to looking at rules that are obsolete, not effective, burdensome, complex, that same thing applies in probably a larger sense based upon what we see in the statistics and based upon that graph, that we would urge you to also concentrate and focus your energy on the President's health care plan moving forward. With that, my time is expired, and we recognize the gentleman from California, Mr. Waxman.
Thank you, Mr. Chairman. Dr. Gleed, regulations have two sides of them. There are downsides because we're requiring some industry to have to do something often, or regulations mean we're regulating certain activities, but there's an upside to it, and sometimes we don't hear about the upside, especially in this committee. For instance, there are estimated 19.4 million children living in this country with pre-existing conditions. Until last year, it was perfectly legal for insurance companies to discriminate against these children, issuing riders that excluded coverage for critical medical problems or refusing to cover these children at all. And when the Republicans said they wanted to repeal the ACA and then replace it, I would have thought they were just saying they were going to replace some of these very same provisions. Otherwise, what are they doing to help children and families, Americans that can't get insurance because they're being discriminated against? Is it true that extending coverage to children with pre-existing conditions provides benefits to the children, their families, to the country as a whole?
Yes, sir, it certainly does. And I think it also improves the efficiency of our economy, because by providing coverage to children with pre-existing conditions, we make it easier for their parents to choose the right job for themselves and to really seek employment opportunities that might not otherwise be available to them.
Now, HHS has also issued regulations to end the lifetime caps on coverage, prevent insurance companies from using decades-old paperwork errors to justify canceling someone's insurance as soon as they get sick. These practices also have costs. They may cut into the insurance industry's bottom line. But Dr. Gleed, in issuing regulations that ban the practices, did HHS determine that such bans would have significant benefits? They
certainly did. We certainly did. In fact, the estimates are that those consumer protections in the Patient Bill of Rights would increase insurance premiums by 0.04% between 0.04% and 0.02%, a tiny increase in cost. And in exchange for that, all Americans would get reliable, valuable coverage. And about 25,000 people who already exhausted the lifetime limits in their coverage would actually have meaningful insurance for the first time.
We hear a lot about burdens on industry from our Republican colleagues, but I think a conversation about HHS regulations that focuses exclusively on costs borne by the insurance industry is dangerously misleading. To understand the real impact of regulations, we have to consider the health benefits and cost savings offered to consumers as well. And I assume that HHS considered the full range of both costs and benefits in issuing these regulations.
Yes, sir, we did.
Many of my colleagues on the other side of the aisle have raised concerns that these regulations under the Affordable Care Act were not subject to retrospective review that HHS conducted. In the executive order issued in January, President Obama cited a number of principles of regulatory review. The President required regulations to be proposed or adopted only when benefits justify costs. He asked for regulations to be tailored to impose the least burden on society, and he called for regulations to be adopted through a process that involves public participation. Dr. Gleed, I'd like to ask you some questions about regulations issued under the Affordable Care Act and the manner in which they were promulgated. Did the department issue regulations under the ACA only when it found the benefits of a rule outweighing the costs?
Yes, sir, we did.
Can you provide some examples of regulations issued under the Affordable Care Act where the benefits outweigh the costs?
Well, for example, the regulation that requires that insurers allow young adults up to age 26 to remain on their parents' insurance coverage is estimated to increase premiums by about 1% for families and to cover over 1 million young adults, up to 1 million young adults. And that will improve the earnings of those young adults, reduce uncompensated care, improve job mobility within the American economy, so the benefits are enormous.
In his executive order, President Obama emphasized the importance of public participation in the rulemaking process. He wrote, quote, "Regulations shall be based to the extent feasible and consistent with the law on the open exchange of information and perspectives among state, local, and tribal officials, experts in relevant disciplines, affected stakeholders in the private sector, and the public as a whole." Dr. Gleed, can you explain how HHS incorporated public participation into the rulemaking process under the Affordable Care Act?
Yes, sir. As you know, the rulemaking process has periods of public comment built into it, but we went well beyond those required periods of public comment and actually solicited public comment even in advance of beginning our rulemaking around the medical loss ratios, rate review, exchanges, and so on. We held open forums around external review and co-ops. We've been very proactive in getting out there and asking stakeholders to give us their views.
Well, I know that the Republicans have a fervent opposition to the whole law, but I hope that that doesn't cloud their ability to thoughtfully examine the administration's steps to apply executive order principles to the health reform regulatory process. I know that they would want those principles applied to all regulations, which is what the President intended, and opposition to a certain law, it is the law, shouldn't affect their appreciation that the department, in your case of HHS, has tried to keep within the President's executive order and following the regulatory procedures that would weigh the benefits and the costs and do what's best after full participation of all the parties in establishing those regulations. Thank you, Mr. Chairman. I yield back my time.
I thank the gentleman. We recognize the gentleman from Louisiana, Mr. Scalise, for 5 minutes.
Thank you, Mr. Chairman. If I could, I'd like to ask a little bit about the waivers that have been issued for Obamacare. We had a hearing on the issue in general, a lot of unanswered questions regarding the number of entities, both businesses and labor unions, that have requested and received waivers, a lot of unanswered questions about who's requested and been denied waivers. So first, if you can give me kind of the broad brush of the administration's policy on this, how long have waivers been granted, and can you further expand on who has not been granted waivers and why?
So the criteria that we use for providing waivers are around the annual limits within the Affordable Care Act, and those waivers are waivers that allow firms in the short run and as a bridge to when we provide people with much better coverage in 2014 to continue to have plans that have annual limits in them. So the waivers allow plans to maintain those annual limits just until 2014. We have the criteria that have been established to grant waivers are up on the HHS website and are available, as is the complete list of all of the entities that have been granted waivers. And sir, fewer than 2% of the health insurance market is in plans that have been associated with waivers. So waiver.
Yeah.
Yes.
How many? If roughly 1,400 entities have been granted waivers, those are the most updated numbers I have. I don't know if you've got more updated numbers. I think 1,372. entities, employers, unions, other entities, have been granted waivers? What numbers do you have?
Those are the numbers. I'm not familiar with other numbers, sir.
Okay, so you would say that that's a fair number to use,
I believe so.
and that's who've been granted. Do you know how many have been denied, who have requested a waiver but have not been granted it?
I believe the list of entities that were requested waivers and were denied them was actually given to this committee, so you've actually got those.
Okay, and I'll pull those if they're here. When you talk about fewer than 2%, I guess that's of all the companies that provide health care for their employees, fewer than 2% of the companies have been granted a waiver?
Less than 2% of the market is affected by these waivers, yes.
Yeah, and when you say affected, this gets, I guess, into the bigger question. When I talk to small business owners, and this last week we had a district work period, and again I was meeting with small businesses throughout my district, and I hear this from other colleagues of mine. Small businesses I talk to, they don't even know that there's the ability to go get a waiver. Many of these companies you talk to are struggling right now with how they're going to comply with Obamacare. One thing they do know is that it's going to be very difficult for them to comply, and they still don't know what all the rules and regulations are because there's still many rules and regs still yet to come out. But what they do know from what they've already seen and what they've calculated, it's going to be very difficult for them to comply. And when I ask them about this waiver process and talk to them about the nearly 1,400 entities, many of whom were ironically entities that were asking for the bill to be passed. I mean, you get groups like AARP, a lot of these organized union groups who were up here at the Capitol saying we need this law, it's going to be so great, and then they went and kind of got this secret deal with the White House to get a waiver. A lot of these small businesses that didn't want Obamacare in the first place don't even know you can go get a waiver. So was this kind of some secret memo that was leaked? I mean, why is it that our small businesses who are on the front lines of creating jobs in America, many of whom can't go and create new jobs because of this law and other regulations like it, they don't even know that this process is out there. When I tell them about it, they say, look, I'd love to get the waiver. And of course, they're not even aware of it. I direct them to, go apply. I'd love everybody to be able to get a waiver from the entire law, meaning repeal of the law. But can you tell me what process y'all use to promote it? Because it seems like a lot of the administration's friends know about it and got the waiver, and a lot of small businesses across America don't even know it exists.
The waiver process is, the information about the waiver process is publicly available on our websites, and I think insurers particularly are very well aware of it. They're the ones who are selling the policies to small businesses that have the annual limits, if they have annual limits in them. Remember that the waiver is only applicable to one piece of the Affordable Care Act.
Right. I mean, it's an important piece of it, though, and it's a piece that many employers seem to have a problem with compliance on. In many cases, it's going to be yet another determining factor on whether or not these employers can continue to provide health care to their employees, and their employees like the health care plan.
So it is providing the annual limits are the annual limit regulation means that the health insurance that people buy actually has real value to them if they get sick. And the annual limit waiver process is simply a bridge to allow people to keep that coverage only until 2014, when we'll have a much better insurance system available, particularly to small businesses.
They're already paying higher premiums, but hopefully we don't have Obamacare on the books anymore. But it just seems like there was a favoritism that was shown because, like I said, ironically, a lot of the companies and entities that have received the waivers were many of the same that were working with the administration to pass the law, and many of the people, our small businesses, our job creators across the country who didn't want this in the first place, don't even know it exists. So, again, it just seems like a real peculiar situation that seems like some of the biggest proponents of the law and the favorites of the administration are the ones who know about it and got the waivers. People who don't want it didn't even know it existed. I yield back.
I thank the gentleman. I'll continue with my questions. Mr. Waxman made some points in his opening statement. I thought I'd follow up, Dr. Gleed. He indicated, he referred to the ban on pre-existing exclusions for children. Are you aware that since passage of the President's health care plan, many insurers have opted not to offer child-only policies? So because of what the regulation says, they're getting around it by offering no child policies. Did you know that?
I think it is horrifying, Chairman Stearns, that any insurer would choose to deny providing coverage to children who are sick. And I think it is one of the reasons that we needed the Affordable Care Act in the first place. Beginning in 2014, these practices will not be possible, and insurers will be providing insurance to all Americans. In the meantime, the administration has taken serious steps to make sure that children who have been denied coverage because of insurance company practices can get it within every state.
So how would, for example, in the state of Florida, if the insurance company did not provide it, how would a person get it for their child?
Chairman, I'll have to get back to you about the details in Florida. Different arrangements have been made in different states.
Let's take your state of New York. How would you do it in New York?
There's not a problem in New York because we have community rating and guaranteed issue already.
So the person would just apply?
Yes, there is no problem in New York.
This whole question, we wrote a letter to Mr. Waxman, in all deference to him, last year, asking for a hearing on this. We never heard back, so he's making a point about this, but I just want to make it clear that we're on record of asking for a hearing on this. He also mentioned that the ban on annual limits, this obviously could lead to increases in premiums or loss of coverage. Don't you agree?
Mr. Chairman, the basic economics of insurance says that insurance is most important and most valuable to people when it protects them against catastrophic losses. That is, very high losses. Insurance that includes annual limits doesn't meet that basic economic test for value. It's really critical that we get rid of those lousy policies.
Mr. Scalise mentioned the waivers. These waivers are only good for 1 year, right?
Correct.
So these 1,400 people that got waivers, McDonald's, Waffle House, 7 states, they're all going to have to come back in a year, right? Would you be giving them waivers again?
I believe that the annual limit waiver process is under discussion right now. I'm not aware of where it's going.
But isn't the reason why you have these annual limits, that this is why you have annual limit waivers, is that correct?
The reason we have annual limit waivers is that we need to get from here to 2014. These provide a bridge until people can be assured of better, more valuable insurance coverage.
When you pass legislation and you suddenly give out 1,400 waivers, wouldn't that tell you something about the angst, the feeling of the people who are asking for those waivers, they can't comply? Don't you think that that shows that perhaps, and as Mr. Scalise said, I don't think anybody in my congressional district knows they could get a waiver either. So if you really put the word out, I think you'd find thousands of people asking for waivers.
That would be very disappointing, Chairman Stearns, because it would suggest that the magnitude of the problem of really lousy insurance policies in the United States is much greater than we had anticipated.
That's funny. I would interpret it differently. That's your interpretation. My interpretation is that people do not want the President's health care plan, and they can't comply with the existing strategies and objectives that are outlined in your legislation, and they want out. Because if they thought it was going to be something they can comply with, they wouldn't ask for a waiver. And in fact, the graph that we showed you clearly shows the small businesses, 80%, are going to get out and just say, forget it, we're not going to be bothered, we'll just pay a fee and just let all our employees go into to the government plan. So that's my opinion. Anyway, let me ask you another question. The key to this whole health care debate is, what is the essential benefits package? That, I think, people have been asking me, what is the essential benefit package? And everybody's talking generalities. But what is the administration going to require, and what is the rule? Are you familiar with the rule yourself?
Yes, sir.
And when will it be released? What date?
So, sir, we're waiting for the Institute of Medicine, which was commissioned to do a study to provide us with principles for determining the essential benefits package. In that report from the Institute of Medicine, which is this expert group, is not expected until late September. Beginning then, we will be working on developing the notice of proposed rulemaking that will include the principles around that.
Within the legislation, they had sort of outlined what the essential benefits package. So here we are, sometime after the passage, and yet you're saying that the essential rule will be released in September of this year? Is that fair to say?
The Institute of Medicine, so the President's plan says that all Americans should be guaranteed a package that includes 10 critical categories of benefits,
right,
and that is similar to that offered to by a typical employer today. So that's a very basic standard of benefits that all Americans should be entitled to.
So it has to be 10. It could
There are
be
10
11.
categories
10
of benefits
categories.
that,
But it could
that
be
Congress
more.
passed.
There could be more categories, or is 10 the
It says that there are at least 10 categories that are laid out in the legislation.
Okay.
Those are things like hospital benefits, pharmaceutical benefits, things like that.
Right.
Those are the categories. We have asked the Institute of Medicine, which is an august body of experts, to help us in defining a process for developing those benefits.
All right.
They have been meeting for 6 or 8 months.
No, I understand.
They've got a lot of
It's
public
a,
input. It's a very challenging project, and so
challenging,
we're trying to get
gargantuan.
as much information as possible.
And
before
not
we do it.
everybody's going to be agreement on these 10 essential benefits. I understand that. But I would just like to pin down a date. Can I say by 15 September this rule will be released?
No, sir. We're waiting for the.
How about 15th of September next year?
The Institute of Medicine is coming back in
Well, no,
September.
what-
Wait,
Okay.
pardon me. The Institute of Medicine is coming back in September. Then we will go into the rulemaking process. We are likely to put out a notice of proposed rulemaking. Then, of course, you would want us to wait for public comment on that before we finalize the rule.
And public
This is a
comment will be
process.
60 days?
It will be. I don't know how long it will be. I believe that there's a minimum, and I confess I apologize. I don't know what that minimum is. It can go longer
No,
than
no,
that.
I understand. But let's just try to come up with a timeline. You're saying the report, this analysis, this study will be done by September.
At some point in
And
September.
then after September, they'll issue a rule within 30 days, 60
I
days?
don't exactly know. I am not privy to what exactly the timeline
We'll
is
get
on
a
it. We are
rule
working on
before-
that rule.
Before next year?
We are working on the development of that rule. And there will be a notice of proposed rulemaking that will go out and that will lay out that and other elements.
So when you sit in a meeting and you talk about the most important aspect about the President's health care bill, what the essential benefits package is, no one ever says there's a drop date dead when we have to get this done. No one ever says that in the meeting. No one ever says we should get this done by X time. They just say we'll just do it when we do it. Generally, in planning of something of that magnitude, there's generally a timeline. You and I both know, and I think you would respect the fact, in your position, you would come up with a date. Let's shoot for this date. But you're telling me there is no date, there's no one that's asked a question, what's the drop date, and you're just sort of winging along month after month.
We know that we need to give this information to states and exchanges so that they can lay out the
What
rules
date
for
do you
their
have to give
employees.
it
But
by?
the exchanges need to be up and running.
Anyone on staff could tell us what date you expect to give it to the states?
I don't think that there is a date that has been written down. We are trying to figure out when we can do this, and there are a lot of issues that are pending right now.
It's a little puzzling, don't you think?
The key here, I think, sir, is that the basic structure of the plan is very much defined in the legislation itself, which calls for it to mimic a typical employer plan. So there isn't that much leeway here. We are trying to lay down the specifics of this and many other provisions in the law through regulation, and this is one of them.
You're building a ship, and you got 10 aspects, categories of the ship that have to be built, and they all have to be coordinated, and everybody agrees upon it. But I'll tell you, there's a date when that ship expects to be done, when that ship is complete, and everybody knows it. So you're telling me here that the essential benefits package, no one in your office, no one in any meeting has ever said to you when there's going to be a date when we can provide, one, for the public comment, two, for hopefully for the states to comply. You can't have it
Sir, I
2014.
I am aware that the notice of proposed rulemaking, which will include the essential health benefits, is supposed to come out this fall. I don't have an exact date when in the fall.
I mean, you're not going to go through a trap door here. If
No,
you come
I
up
don't
with
know
a date,
exactly what date it is in the fall. It
because
is
this trap door doesn't exist.
The
All
fall
you
is
have to
when we're
do
doing
in your
this.
best estimation,
It will be in the fall,
as
sir.
the crowning chief here, is to give us a little date.
The fall. When is the fall? I don't know. When
The leaves turn in
the
October.
leaves turn in October. It's likely to be in
Okay,
October.
so
It
we're
could be
gonna
in
say-
November, sir. There you go.
So we're going to say in October is when the rule will be released. Now, if you come back...
It may be November. I don't want to be held to October, sir. I don't know.
Now, if I was a businessman and I felt that I wanted to work with you,
Yes, sir.
this uncertainty that you're creating by sort of double-taking on this date provides me a feeling that I better not do anything till I start to see this essential rule. So you're an economics professor. You and I both know that uncertainty in the marketplace is not a good thing. Isn't that correct?
That's correct, sir.
So you are creating uncertainty by giving us such a nebulous span here of you're not sure of a critical aspect for the rule to be released on the essential benefit package. So I would just suspect that if I went back to your people, you could say, look, why don't we give the Oversight and Investigation Committee the best guess at what we can do? Because that would be better certainty than you're giving me today.
I will be very happy to go back and see if we have a date that we would be able to give to the Oversight.
Now, during this process, are you going to meet with stakeholders?
Yes, sir. We actually have an extensive plan for public comment. That's one of the reasons we want to get the NPRM out.
What individuals in the administration has HHS discussed this rule with, if any?
Within the administration?
Yeah, in other words, I assume these 10 categories that you're talking to other people within HHS about these. I mean, who is this cadre that we're talking with?
So the 10 categories, of course, are laid out in the legislation itself, as is the
I know the
requirement,
categories
right?
are, but
and we've
how about
already
the
done
people?
work. We've released, for example, a report from the Department of Labor looking at what typical employer plans include.
I'm not being too clear on the question. When the FCC came up with the broadband plan, they went out and brought all these stakeholders in to help them write it. We didn't like some of it. And then they paid them money, and they also had staff. But you're not doing that.
No.
You're not bringing in stakeholders to help you write the essential benefits package. You're all doing it in-house.
No, sir. That's actually one of the reasons we went to the IOM. The IOM is actually already engaged in a long period of public engagement.
Who is the IOM?
The Institute of Medicine. They
Okay.
actually held 2 large public meetings back in January and April. They're about to
will they
release
be
the
writing
reports
the
on
rule?
those meetings. They will be providing us with this process. We will then be working on the rule. We will be engaging stakeholders. We are actually developing a plan for actively engaging all types of stakeholders. Then we will release an NPRM and get even more stakeholder comment. This is actually anticipated to be a very public process. But we have to wait for the IOM report since we did commission it.
Okay. My time's expired. The gentleman from California, Mr. Bilbray, is recognized for 5 minutes.
Thank you. Look, Doctor, I'd like to try to do something very unique in the oversight hearing process. I'd like to work with you to come to a consensus of a strategy we should go to. Rather than talking about stakeholders to, someone to the left means political activists, stakeholders, somebody to the political right means the business community. Let's talk FDA and let's talk about real stakeholders. Patients, people who are ill,
Yes, sir.
people who are dying, people who are waiting patiently for something to save their lives. Let's take a look at something that I think all of us can agree was a bipartisan effort that probably was more of a medical movement or success than anything we've seen probably since polio. And that is in the 90s. We not only put massive amounts of research out there, but we changed our FDA oversight and regulatory guidance for AIDS. We did things to fight the AIDS epidemic that we basically hadn't done in the past, at least in the near past, and we haven't done since, as far as I know. And sadly, I think what happened was we were so successful that we walked away from that success and said, okay, we've really done a great breakthrough here, and pat ourselves on the back, but we left it at that. And this is what my challenge would be to you. What is the possibility of Democrats and Republicans getting together, taking a look at what we did in the 90s to put AIDS in that situation, move it from acute to a chronic, basically make it a livable, survivable process? What is the possibility of us going back and saying, damn it, we had a successful formula here. Why don't we go back and take a look at that? And one of the most important successful formulas was not one of, you've got to have a bureaucracy that is totally insulated from the private sector so they're not polluted by capitalism, or we've got to have somebody who has some reality and connection to the industry so that they know the physical movements. And let me tell you something, as somebody who comes from local government, a former mayor and county chairman, building inspectors are required to have had private sector involvement, and that's one of the most successful local government aspects. But that aside, I think the one place we should be able to agree is that we should be looking at implementing the stakeholders' place at the table, or with all of these FDA reviews, not just on AIDS. And what is the possibility, do you think, of the administration working with us at modifying the FDA process, at least maybe at some targeted issues? Maybe we talk about cancer, maybe we talk about diabetes, but changing the oversight process to allow patients, not advocates, patients at the table like we did with AIDS? What's the possibility of us resurrecting that model and applying it as being the happy medium someplace the Democrats and Republicans can agree on?
That sounds like a very interesting idea, and I'm actually not very familiar with what the FDA is doing now to enhance patient engagement around medical innovation. I know that they're working very hard to try and improve the speed and innovation process on several different fronts, but I'm not actually sure how much patient engagement has played a part in that.
Okay, let me just tell you.
I will get back to you on that.
Doctor, if there was any place that I think the administration really is very vulnerable, and I praise the administration on Secretary of Energy. I praise him what I think has been, you know, as a Republican, to praise him about the team he put together for national defense. But if you look at the timelines, since this administration has taken over, and granted it might be a timeline that started a little bit before this administration, patients are watching the clock slow down. They're watching it so much to where we end up with what happened this week, where you had the First Lady, rightfully so, point out that obesity is a major crisis here, and at the same time the FDA telling a drug company that may have a major breakthrough in obesity, we're going to require you to go to a 60,000 test site number, and that they're just basically saying, forget it, they're packing up and going to Europe. At the same time that our system is doubling in certain applications, Europe is reducing their numbers with no more adverse impact. So if I can say frankly to you, I think we're in crisis at the FDA, and I'm trying, rather than just screaming bloody murder about patients are waiting, on a death list while the bureaucrats are fiddling. Why don't we take a look at, okay, let's go back and maybe we can both work together and learn from the past and move it forward.
So, the FDA has to balance patient protection and trying to take care of patients in need, and I understand that you know that too. Let me get back to you on some ideas that...
My biggest point is this. It's, as somebody who's worked 35 years in bureaucracy, I don't care if it's FDA, I don't care if it's a planning director, I don't care if it's somebody putting up stop signs. It's much easier to say stop than it is to say go. There's risk at go. The fact is, the bureaucrat doing the oversight isn't at risk when he says stop. The patient who's dying of cancer, who's dying of AIDS, they're at risk, and they should be able to sit at the table and be able to look the bureaucrat in the eye like they did on AIDS.
Let me get back to you on what's happening on the FDA, because I'm just not very familiar with that, sir.
Then all I ask that we look at this and bring in some balance, and I think that we've got to understand there isn't balance now. As long as you have somebody who's coming out of the government structure and has no personal vested interest in the outcome, you're going to have it. Now, some people say business there would have too much financial vested interest, but I think we should both agree that patients have the right type of vested interest, and so they will encourage and let me say force the process to be more responsive without it be opening itself up to being abused by the private sector. And I hope they'll leave that as an open invitation.
Okay.
Thank you. I yield back, Mr.
Gentleman yields back. The gentleman from Louisiana, Mrs. Cleese, is recognized for 5 minutes.
All right. Thank you, Mr. Chairman. When Mr. Stearns was asking you kind of a follow-up about the waiver, you had made a comment that when he said, all of these 1,300, almost 1,400 people have received a waiver from the component that would take effect in 2014, you had said that shows that there's a lot of lousy plans out there. I'm not sure if you're familiar. They're not asking for a waiver from their plan. They're asking for a waiver from Obamacare. So can you explain what you meant by that comment?
Yes, sir. They're asking,
comment to make.
They're asking for a waiver from the requirement in the Affordable Care Act that says that plans may not limit the amount that an insurance plan will pay out to a person who's very ill. So right now there are plans before the Affordable Care Act came out that would say this plan covers you unless you have more than $5,000 in medical expenses. And after $5,000, hey, buddy, you're on your own, which actually means, hey, the rest of us, we get to pay your bills because you're not going to be able to do it.
So
the Affordable Care Act,
so I guess what you're saying is saying then you've defined that yourself as that's a lousy plan. Is that what you're saying?
Basic economic theory, as well as I think U.S. taxpayers ought to see that as a lousy plan because we're going to pay your cost for you if you have.
So if a family has that plan and they like that plan, you're sitting here in your ivory tower saying that's a lousy plan. We need to fix it. We need to go and change the rules in a way that your employer might drop your coverage altogether. Because that's what these employers are saying. The employers aren't saying, I want I want to try to figure out how to add costs to health care in a way that they can't afford. They might go bankrupt. They've decided I can either provide health care to my employees or not provide it. And if I can provide a plan that gives their family something that their family likes, you're sitting here saying that's a lousy plan. We're going to change the law in a way that now you can't afford the plan anymore. The companies have told you. This isn't me suggesting it. You granted them the waiver because they said they can't afford it. They're going to have to dump all their employees off of that health care plan that you just called lousy. They like the plan. 80% of the employees like those plans, and you're calling them lousy saying, oh, no, but if you get a waiver, you can keep doing it. But if you don't get the waiver, your employer's going to dump the plan because they can't afford to do it anymore. So now you don't have any insurance, and you're off fending for yourself out there because you decided in some ivory tower that their plan that they liked was lousy. Now, you don't understand how a lot of people have trouble with that concept that somebody in Washington is now going to determine that their plan that they like is no longer valid, and if they get a waiver, they can keep getting it. But if they don't get a waiver from you, their employer said they can't provide it anymore. They're going to have to stop providing health coverage to their employees altogether, and now that plan that they liked is no longer available for them.
That, sir, is why we need to move to 2014 when everybody will have much better, more affordable coverage available to them. And the reason for the waivers is just to keep those plans, which we recognize are better than nothing, in existence until we can provide people with much better coverage that is comprehensive and that protects them against catastrophic expenses beginning in 2014.
Well, there's a big flaw with that theory, and I'm glad you acknowledge now that maybe it is a good plan because you were calling it a lousy plan earlier. That employee likes the plan. You might think it's lousy. That's not your decision. It shouldn't be your decision. I mean, under Obamacare, I guess it is your decision. You can take it away from them. But the president said, I mean, he pledged it time and time again before, during, and after this debate, that if you like what you have, you can keep it. And frankly, that's a tenet that ought to be established in the law, and it's not. Because if you like what you have, you're going to lose it in many cases. And there was a study done by McKinsey and Company. I don't know if you had looked at it, but a very well-respected firm who did an in-depth study, the only one I've seen out there that really goes into detail about employers who do provide health care. It said 30% of employers would drop their coverage when all the costly requirements of Obamacare become law. Now, I don't know if you've disputed the McKinsey study, but it's out there. It has a lot of factual basis behind it. They talk to real people. They talk to employers who provide health care, to employees who like the care. And so when the president says, if you like what you have, you can keep it, according to this study, over 30% of those companies said they're not going to be able to keep providing it, so the employees lose the care they like. That breaks the president's pledge. Now I'd like to see what your response is to the McKinsey study. Maybe it was flawed in how they asked the question. Maybe you think it's going to be a lot rosier when all those lousy plans are dumped as you categorize them.
So, sir, we've actually seen many studies. The McKinsey study is only the most recent in a very long series of studies. Virtually all of them have not found anything like that result. They've found very small changes in employer offering, and including previous surveys of employers. So the McKinsey study is...
the findings of the McKinsey study?
Wait a second. And moreover, we have one real-world example of what happens when you do something very much like the Affordable Care Act, which is what happened in Massachusetts. And what happened in Massachusetts is that the number of employers offering coverage increased substantially and significantly, even as the rest of the country...
all kind of problems with Massachusetts.
Well,
regardless
certainly
of that,
whatever...
This isn't Massachusetts. This is the United States, and you've got 1,400 companies that your office has said they need a waiver, otherwise they're going to have to drop the plan. I mean, if 1,400 entities, you know, unions and all kind of other groups that were supporting this law said, we can't provide the health care anymore unless we get the waiver. Well, what happens at 2014 when they can't get the waiver anymore? What happens to the countless others who have asked for the waiver and couldn't even get it? Now 30% of them, according to the study, but even if you don't go by this study, 1,400, according to your own numbers of who you gave waivers to, said they couldn't provide health care to their employees anymore. They were going to have to dump them if they didn't get the waiver from this component of the law.
Beginning in 2014, everyone is going to be assured much better, more comprehensive and affordable coverage. Right now, fewer than 2%.
I guess something magical happens in 2014 where today they're going to have to drop. They can't even comply with the law. But in 2014, somehow everything's going to be rosy, and then they can comply with the law even though nothing's changed because all of these other companies have said they can't comply. They're going to have to dump the health care that their employees like. 2014
will have a new, much more competitive, patient-centered insurance marketplace in which people will be able to get coverage they can afford. So
hopefully by 2014 the law is repealed and then people really can keep what they like that they currently have. Thanks. I yield back.
Gentleman yields back. I have a series of questions here. Dr. Gleed, I Are you familiar with the recent rule HHS released on accountable care organizations?
Yes, sir, I am.
Are you aware that a number of premier organizations, such as the Mayo Clinic, wrote the administration saying that more than 90% of its members would not participate because the rules, as written, are so burdensome it would be impossible to succeed?
Yes, sir, that's exactly why we want to have a robust public comment period after we put forward a notice of proposed rulemaking.
If less than 90% of the groups that you need to participate would not do so, how did it come about that a rule was ever released?
There are we have received many comments on the notice of proposed rulemaking, and they vary considerably in what they think should and should not be in the rule. The administration has to chart a course between all the different goals that we're trying to do here, and we really want to bend the cost curve and change the delivery system. So we are listening to all the comments, and we will incorporate them in the final rule.
But wouldn't you think that the reaction was pretty dramatic here? That the Mayo Clinic, I mean, if you're trying to create these efficient rules and balance the competing interests, so-called, versus the government versus the private sector, you know, shouldn't the reaction to a rule like this not be so harsh? I mean, doesn't that tell you something? This is
a very important rule. This is one of the main goals of the administration, is to bend the cost curve by changing the incentives that face the healthcare system today. And of course, there are lots and lots of opinions about how it ought to be done. It's not at all a surprise that we've heard a lot of feedback. We also took a lot of public comment before we wrote the rule that's incorporated in it already.
The complete rejection of this rule by organizations you would need to rely on for its simple success seems quite lopsided. I mean, that's our opinion. Do you agree?
It will be it's important to wait until the final rule is promulgated, and the program is supposed to take effect at the beginning of next year, and I think we should wait and see what happens at that point. We are really working on improving the rule and listening to the comment, and I can't really speak to it any much more.
I think this quote is from the Wall Street Journal. It called it, these regulations have been called, quote, overly prescriptive, operationally burdensome, and the incentives are too difficult to achieve to make this voluntary program attractive. In light of these statements, shouldn't this rule be completely reworked?
We are responding to the rule by looking at the comments that we've received. Remember that we have to balance the protection of the Medicare Trust Fund against our desire to change the incentives in the healthcare system. Both of those are competing interests, and we're working on.
So you don't think the rule should be reworked?
Mr. Chairman, after an NPRM, we rework a rule before we finalize it. We listen to the comments and we change it around.
So it can be reworked.
That's the point of this process.
Does the President's executive order require you to do this, or do you consider that, or is this just part of your normal procedure?
It is part of our normal procedure.
Yeah, okay. One thing many have wondered in the aftermath of the rule, how did this rule come to be? For example, we talked earlier about you communicating with stakeholders. Evidently, you didn't communicate with stakeholders in this case. Is that true? You didn't communicate with stakeholders? That's why the reaction was so harsh?
No, sir. We had extensive communications with stakeholders, and this has actually been an area where there's been tremendous public comment.
And the stakeholders didn't alert you to the problems back then before you issued it?
Different stakeholders had different opinions, sir.
Ah, okay. So you're going to reach out to these same groups again, I guess, and does that mean that, did you reach out to the Mayo Clinic?
The rule is closed for comment on June 6th. We received many comments on the rule.
Okay. So you're saying to me this morning that this afternoon you'll probably redo this rule.
We are looking at the comments, and we will revisit the rule and look at what we need to do to address those comments.
Okay. I think I'll probably conclude here shortly, much to the loyal opposition's concern. I want to talk about the Data Quality Act.
Sure.
To comply with President's January executive order, doesn't HHS have to base its regulation on the best available science?
We endeavor to do so at all times.
Sure. Okay, what is this best available science that you use?
That will depend, sir, on the question the question that's being addressed, what the science is.
In addition to and prior to the President's executive order, did HHS have to base its regulation on the best available science pursuant to the Data Quality Act?
We have always tried to base our regulations on the best available science.
I think that's a yes. Since that is the case, can you represent to the committee today that all HHS regulatory efforts since you have assumed office have applied the Data Quality Act since you have assumed office, have applied the Data Quality Act and are in compliance with the Data Quality Act?
I believe so, but let me get back to you because I'm not familiar with the precise details of the Data Quality
That's
Act.
a fair answer. Would you agree that if HHS is to base regulations or regulatory decisions on the best available science, that HHS cannot act on the basis of conflicting studies? For example, if you decide on certain areas and you have a conflicting studies, I guess the question is, how are you going to make your regulatory decisions?
Chairman Stearns, if we waited for science to come to a definitive conclusion on everything, we would never be able to act. It is always going to be there are always going to be conflicting studies. The best available evidence doesn't mean that there are no conflicting studies. It means that the preponderance of sensible evidence leads in a particular direction. Scientists thrive on controversy.
Okay. Mr. Scalise brought up the McKinsey study, and I think your indication was that you weren't discrediting it, but you said there's more than one studies. And I think the White House has tried to discredit this study, calling it an outlier and implying that the McKinsey study isn't a respected independent organization. Did you know of that criticism?
I think one of the concerns we have about that study is that we haven't been able to see the methods that they used, and they haven't made those public. So I can't speak to whether that's a good study or not because I personally have not seen the methods used.
So you're not implying that the McKinsey organization is not a credible organization?
I believe the McKinsey organization is a credible organization. I can't speak for this specific study.
Okay, and I agree with you. The federal government has awarded McKinsey and Company over $182 million in government contracts to perform consulting and analysis work. And as you're aware, that $182 million, that's disclosed on U.S. spending, more than 122 of it comes from the Obama administration, 21 million of which are contracts with HHS. So clearly the Obama administration thinks McKinsey is doing a reliable and honest work, or they wouldn't employ him, and they're spending money with him. And doesn't McKinsey say what distinguishes this study from others is that McKinsey educated respondents on the President's health care requirements that will take effect in 2014. What I'm trying to establish is once McKinsey went out and explained to them the implications, that's how they got their study, and that distinguished many other studies which just do analysis without asking and educating people about the impact of this the President's health care plan. So I guess the answer is yes or no. So all I'm saying is
we don't know how they educated them, so I don't know what that I don't know what I can say about that.
Okay, so you can't answer it. Okay. Okay, I think we've covered most of the questions here. We thank you for your patience, and with nothing else, no more on the minority side. The subcommittee is, before I adjourn, I would just like to let all members have an opportunity to offer their opening statements. And I ask unanimous consent that the written opening statements of all members be introduced in the record without objection. And I ask unanimous consent that the slide we had be put as part of the record. And with that, the subcommittee is adjourned.